So we're going to be talking about myeloma and the neurop of multiple myeloma. So it's multiple myeloma, and it's plasma cell dyscrasia, neoplasm. It's multiple because you have multiple manifestations of the myeloma, not just the plasma cell making a mass. So if the plasma cell makes a mass, then that thing's called a plasmacytoma. And of course, that can cause any kind of neuro-ophthalmologic problem because you have compression of whatever structure is being involved. The plasmacytoma can cause afferent vision loss or efferent Sixner palsy for a clival lesion, a cavernous sinus lesion, etc. However, multiple myeloma is also an immunoglobulin problem. So that's the immunoglobulin. And the immunoglobulin itself can cause problems. And if you have overproduction of the light chain in the immunoglobulin, that thing can self-aggregate and cause amyloid. So we've got compressive lesions from mass lesions from the plasma cell being a mass. You've got the immunoglobulin itself causing a problem, and then you've got the light chain aggregation causing amyloid, which can cause eye problems. So if you just go through that list for the neurop piece, the first thing you got to do is establish a diagnosis of myeloma. And that means you're going to have bone marrow with 60% or more plasma cells, light chain predominance. So you're going to have to do free light chain analysis and kappa and lambda assessments to see if you've got overproduction of the light chain. And then the CRAB in myeloma, which is the calcium, the renal function, the bone lesions, and anemia. So we've got the CRAB, which is part of the myeloma spectrum, and ultimately the diagnosis can be a bone marrow biopsy. But for the eye, if you just use an anatomic structure, it can be cutaneous lesions in the skin or the lids, and that could be amyloid, immunoglobulin deposition, or plasmacytoma. It can be the cornea. You can have deposition of immunoglobulin and light chain in the cornea that can look like little crystals in your cornea or your conj. It can make cysts, and those cysts can be in your ciliary body. It can be amyloid in your vitreous. It can be in the posterior segment and cause optic disc edema. And it can be papilledema from mass lesion, or it can be papilledema as a paraneoplastic effect associated with organomegaly, endocrinopathy, and skin lesions, and that thing's called POEMS. So you've got peripheral neuropathy, papilledema, organomegaly, endocrinopathy, the M spike, the monoclonal gammopathy, and skin changes. That's POEMS. And it can be increased intracranial pressure, causing papilledema. It can be infiltration by the plasma cell, or infiltration by the immunoglobulin in the light chain, or it can be amyloid deposition. And so basically, when you're dealing with myeloma, it can be any place in the visual pathway. And it can be deposition of the plasma cell itself, the immunoglobulin, or amyloid. And you should be thinking about both the direct effects and the indirect effects, like in POEMS, which is a paraneoplastic effect of the monoclonal antibody. And that's why it's multiple, because there are multiple ways that myeloma can get in your eye, and you need to know those multiple reasons when you're dealing with multiple myeloma.